Hello, everyone. It's right on the hour, and we are ready to begin. So thank you very much for joining in. My name is Anafi Mataka from ASLM. I'd like to welcome you to this important workshop. Let me start by saying, if I remember about 2 weeks ago, speaking during a news conference on Monday, the 16th, I think, Dr. Tedros, the WHO Director General, had one simple message to all countries on how to deal with the coronavirus outbreak. And the message was, test, test, test. He urged countries to test more suspected cases, warning that, I quote, they cannot fight a fire blindfolded. And this is one of the reasons why we are actually having this session, and particularly being part of a series of sessions that we've lined up today. Today, we are talking about the latest update on available technology to detect COVID, and as well as recommendations for clinical care and surveillance. We have lined up two presenters today, Dr. Cassandra Kelly from FIND and Prof. Rosanna Peeling from the London School of Hygiene and Tropical Medicine. Just a few logistics as we move on to the call. This will be an hour-long session, which will start by the two presentations, followed by a question and answer segment. Meanwhile, please enter your name in the chat box in the format name, surname, organization, and if you are more than one behind the station, kindly enter all of your names too. As the session progresses, we invite you to enter your questions and comments into the chat box, and kindly mute yourself if you are not speaking. So to introduce the first speaker, Dr. Cassandra Kelly is the Director of the Emerging Threats at FIND. Cassandra previously worked on the emerging infections at the Canadian National Microbiology Laboratory, as well as the Wadsworth Center at the New York State Department of Health, where she served as the Deputy Director of the Biodefense Laboratory. Most recently, she has served as Vice President of Infectious Diseases with DNA Genotech. Cassandra holds a doctorate in immunology and infectious diseases and has developed vaccine and immunotherapy candidates for anthrax infections. For over 20 years, Cassandra's career is focused on development, evaluation, and implementation of diagnostics for emerging diseases. So over to you, Cassandra, to take us through.
Thank you so much. Thank you, everybody. I'm going to just share my screen. Excellent. So I hope everybody can see the slides and hear me okay. Thank you very much for the introduction. And as Anafi said, you know, Dr. Tedros and I think all of us feel very strongly that it's critical that we be able to test as many patients as we can so that we're able to understand what's happening in our country and be able to put in an appropriate response and support our citizens. One of the biggest challenges that we're faced with right now, though, is understanding those diagnostics and which diagnostics to use. So this is what I hope to take you through a little bit today. Just as a quick background, in case you're not familiar with the organization that I work for, we're called the Foundation for Innovative New Diagnostics, or FIND, and we're a global nonprofit foundation that aims at delivering diagnostics into countries, low middle income countries and resource limited settings, for diseases that don't tend to affect the highest income countries who have the capacity to deliver their own diagnostic research and manufacturing. So you can see in blue the main areas of focus for FIND, and within pandemic preparedness, we are obviously now scaling up our ability to support on coronavirus. So for the COVID-19 situation, just a very quick overview. I'm sure you're all very well aware of this, given that you're coming from countries that are starting to see scale and rapid introduction of new cases. But this has really become a major problem across the world, and what we're seeing in the higher income settings is the healthcare systems are becoming rapidly overwhelmed trying to scale testing capacity, and then also to be able to adequately care for the increasing number of patients that are coming in that are presenting with severe symptoms and severe disease. And so in terms of this overwhelmed health system, what's critical is that we understand how do we rapidly implement tests that are going to work in the settings of use that you're going to be faced with, and how do we supplement health systems that may already be struggling to be able to deliver care. So one of the first things that FIND has decided to do in face of this outbreak, usually we would go and actually help develop tests and we would invest in R&D. But as we've seen in the past Ebola outbreaks and Zika outbreaks, when we have outbreaks of this scale, there tends to be a high degree of autonomy in terms of industry partners making tests and making those rapidly available into the market. And so for this, what we decided to do was really focus on the evaluation of new tests and tests that were coming out rapidly. And we wanted to make sure that the tests and the evaluations we're doing were going to be able to inform low middle income countries through partner organizations like ASLM, Africa CDC, the World Health Organization, to be able to understand which tests are appropriately suited for your healthcare systems, and then also for performance, so that we understand which one should be prioritized from a procurement, implementation, and training perspective. We are continuing to monitor the R&D pipeline because there are a lot of exciting technologies that are being developed. However, we don't feel that those are going to be adequately available in the short term to be able to impact the current outbreak. But if we continue to monitor them and support their evaluation, if the coronavirus outbreak continues to progress over the next several months to a year, or if we see recurring outbreaks, they may become extremely important in our response. The other challenge that we're focusing on right now is the supply chain and the pipeline for how to actually get test kits. And as I'm sure you've heard or experiencing firsthand, the shortage of medical equipment and supplies such as swabs and face masks. We're focused on the pipeline for the diagnostic kits, but we understand that there are a lot of different reagents that go around the tests themselves that you still need access to. And we've been hearing from several countries on the ground in different regions of the world that these are becoming very difficult to be able to procure and get access to at scale. So one of the things that we're currently focusing on is trying to understand how do we ensure allocation of tests and reagents are made equally and across the globe, and not just focused potentially into high-income countries or countries where the manufacturers are actually located from a manufacturing standpoint. And then the last thing that we're focusing on are new technologies or RDTs and other technologies that could be easily implemented in a decentralized fashion, specifically to support rapid scale-up of testing in countries that may not have the ability to accept huge numbers of patient samples into their centralized testing facilities. So right now on our website, we have a diagnostic tracker, which is a map that's showing how many tests are being procured and performed in each country. And what you can see is there's a high variability to the number of tests that have become available and are being performed across countries. But we have a huge number of tests that are already being performed, but this is a drop in the bucket compared to the number of people that ought to be being tested. And from what I hear, this is not from lack of desire to test, it's from lack of access to the tests. And so what I'll take you through are the different kinds of tests, what we're doing to be able to provide the data around the performance of those tests, so that each of you at your own institutions can try to make a decision about which ones you would prioritize as soon as they become available for you to be able to implement. So what is the goal for testing for coronavirus 19? So there's two main goals. Either you were looking to stop transmission and prevent spread, and this is most applicable in country with no cases, which today, I don't feel that we're speaking to anybody in that situation. If we are, then I applaud you and I hope you stay that way. However, I would be worried that you will move into the other bucket. But really, if you have small sporadic cases or clusters of cases, then you might be able to use testing to contain those cases, stop the transmission, and rapidly prevent spread. However, what we're seeing in the majority of countries worldwide right now is the sustained community transmission of the virus. And so our goal really is to use testing to slow that transmission reduce the case numbers, reduce the impacts that we're seeing to the healthcare systems, and to minimize spread of severe disease to at-risk populations. So who should be tested? And I'll take you through a little bit of this, and I do believe that at the end, Rosanna Peeling is also going to present on some interim guidance around how to use different tests for the testing algorithms. But one thing that we've been talking with our partners on is the use of clinical symptoms and epidemiological factors, including exposure risk or known exposure to other patients or people that have been confirmed positive. So one of the things is using PCR testing of asymptomatic or mildly symptomatic contacts has been considered in the assessment of individuals who have had contact with a previous known COVID-19 case. And the idea is then that you would be able to rapidly collect and test for patients meeting the suspect's case definition. And that would be a priority for making decisions around clinical management. So do you accept the person into the hospital? Do you ask them to self-isolate if their disease is not that severe? And then how do you use that data to approach your outbreak control measures? So if you look to the case definitions for guidance on testing, you have your apologies. Okay, I'll keep going. The case definition, so you've got your suspect case, which either is a person with respiratory illness or disease, history of travel or residence in a community that's reporting community transmission during the past 14 days prior to onset. And you could use a probable case definition for the person without testing, or if the testing is inconclusive. And then confirmed for that suspect would be a person that has actually had a confirmatory COVID-19 test, irrespective of clinical signs and symptoms. And so you may have a range of patients presenting either with illness and contact or no contact and still presenting with respiratory illness and acute COVID-19 symptoms. And this is because we are now seeing the community transmission. And so one challenge that we're seeing for many countries is as they can't access tests, the way that they're counting patients is variable. And a lot of countries are now taking to considering anybody presenting with symptoms consistent with coronavirus infection are being counted as coronavirus infected and being added into the country caseload. So you can also visit the WHO for their laboratory guidance and details. But really what this brings us to is what types of tests are going to be used to be able to identify patients that are suspected of being infected with coronavirus. And then how do you use those results to apply them to your country's response? So if we look at the different kinds of tests that are available against coronavirus, you can see that there's molecular tests and immunoassay tests and non-disease specific tests. I'll touch very quickly on the non-disease specific tests. These really are clinical symptoms and signs of disease. They may include taking your temperature, perhaps at more sophisticated sites, a CT chest scan to evaluate the infiltration in the lungs. It's not usually performed in a laboratory, and it may really be used as a screening and triage to make sure that people go on to further testing for confirmation. From the molecular test side, this is now considered the gold standard test for confirming if patients are infected with coronavirus, as it's the most widely available in all the centralized lab facilities. And it's detecting the presence of viral genetic material, in this case RNA, from a nasal swab. It's based on polymerase chain reaction or reverse transcriptase, and it's usually needed to be performed in a laboratory due to equipment requirements. So it can still be a heavily complex test to run, although I will get into different variations of the molecular test that can be run in a more decentralized way. And it's most commonly used for testing people suspected of having COVID-19, and it does confirm an active infection. So this is critical to remember. Sorry, I'll go back one slide. And then the immunoassays there's two different kinds of immunoassays, and they can be in a rapid test format or they can be in a laboratory ELISA-based format. So it's important when we're speaking about the rapid tests, which are a common topic for discussion right now, that we make the distinction between what the application of that test is so that we understand if we should be using an antibody-based test or an antigen-based test. So an antibody-based test, it actually detects the presence of antibodies that your body has mounted after infection to the virus, versus an antigen-based test, which actually detects parts of the virus, the actual antigen particles that are present in your nasal swab, if you're infected with the virus. So the antibody-based test can actually be used for a couple of different applications. It can be used to assess your infection, as well as immunity rates within a community. The antigen-based test, however, is good for screening and triage and confirmation potentially, depending on the test design and the performance, to confirm a patient has, in fact, currently been infected with coronavirus 19. It's important to note that for an antibody-based test, it has no ability to distinguish between a recent infection or a past infection. And as such, you could potentially either miss an active infection because your antibody levels have not been sufficiently risen in your body to be detectable by the test, and yet you could still be actively infected with the virus and potentially still shedding and contributing to community transmission. Or it could mean that you were recently infected in the past, but we do not know how long you would have lasting immunity, and also whether or not you would be actively shedding, depending on how long your symptoms have been around. The antigen-based test, as I mentioned, confirms a current infection, but does not tell you anything about your past exposures or your immunity levels. So if we just quickly switch to talk about what samples are used for these tests, because they're critical for understanding how to implement the tests and how easily they're going to be able to be used depending on the setting of use that you're most interested in. Nasopharyngeal swabs are most commonly taken right now for coronavirus testing. Other sample types can be included depending on the test format and the analyte that's being looked at, including sputum, blood, which would be really only limited for use in terms of antibody testing, stool or urine, as we've heard, and we've seen scientific reports stating that some people, predominantly children, do shed the virus in stool, and bronchial lavage as well. If this patient was in the hospital, most likely this would be the only place to take this sample. Samples may be taken at home by visiting a healthcare professional at a drive-through center. In this case, usually the samples are taken through a car window and then they're sent off to a centralized testing facility for confirmatory testing. At this point, we don't hear that there's any rapid tests being done in these drive-through centers and at a hospital or a clinic. Samples are generally still, as I just mentioned, sent to a laboratory, a centralized facility for testing. However, as we talk through the rest of the slide deck, we'll get to the use cases for the rapid diagnostic tests and how powerful they could be for a decentralized response. If we look at molecular tests for coronavirus, we have opened up an expression of interest to evaluate different molecular tests, and we had over 220 applications for review. So you can guess at the number of different tests that are out there, because we don't assume that we've seen them all. But what they are all based on is the genetic sequence, as I mentioned before, the RNA sequence from the virus itself. It requires an upper or lower respiratory sample. And the test is quickly able to distinguish between other circulating coronaviruses and the SARS coronavirus 2 based on the design of the assays that have been implemented. A molecular test requires a whole series of basic ingredients to go into the individual kits. This includes enzymes and primers and probes, the nucleotides, the buffer solution. You need to have an extraction kit or procedure that surrounds these tests so that you can actually get the viral nucleic acid out of the virus and then prep it and be ready for amplification with your amplification kit. And it also needs a dedicated machine to do the thermocycling or the heating and cooling of the samples so that you get the PCR reaction and the subsequent result. On the right-hand side, you can see at the top there's some what we call open molecular systems, or they're flexible. So these can take reagents from a series of different manufacturers, such as Altona in the middle, to be able to run different molecular assays for coronavirus. So you have flexibility to pick and choose what series of tests and kit components you're running. However, this does require some infrastructure that I'll talk about in a moment that you may not have access to in a decentralized space. At the very bottom, you can see a blue and white cartridge. That's the Gene Expert cartridge for SARS coronavirus that have just gotten approval for in the US and are releasing globally. This is more of an automated system where the swab is taken and added directly to the cartridge. The lid is closed, the instrument is turned on, and the cartridge is placed into the instrument, and it performs the nucleic acid extraction procedure as well as the amplification all within the cartridge. So it's a closed system, or what we call an automated system. So if we look again at some differences between what I just described as open and closed systems, there are three main categories, and they're important to understand so that you can evaluate your laboratory and your settings, which are the most appropriate. So if we look at lab-developed tests, these are the most rapidly available tests that came out very quickly after there was identification of the outbreak in China. And there was rapidly moved to a commercial test through a partnership between the developing laboratory at Charité in Germany, the Tibmal Bio, and Roche to be able to scale and manufacture. But what you can see is this was a laboratory developed test and protocol. The viral RNA had to be extracted manually and separately and then added to this test. And the turnaround time is somewhere between 3 to 5 hours, depending on your extraction procedure chosen. It's the fastest way to develop a test, but does require an experienced laboratory. And it's extremely difficult to be able to scale this and make it available globally because it's essentially a very specific test developed by one laboratory. So what happens quickly then is we transfer all of our knowledge from the laboratory developed tests into more commercially available tests to ensure that we have quality control and scale of manufacturing so we can make those tests available globally. And so usually a commercial company will then supply a kit with all of the reagents and ingredients that are needed to be able to run the assay. For an open manual kit, however, you will likely need to order a separate kit for extraction of the viral material from your sample from a different manufacturer. And you will have to have the lab infrastructure and training in place to be able to run the extraction procedure along with the amplification procedure and the interpretation of results. The turnaround time for this is similar to the lab developed test because it essentially is just a kitted or commercially available version of the same test, so 3 to 5 hours. We hope that most of the manufacturers have demonstrated compatibility with a range of laboratory equipment, including extraction kits and PCR machines. And this is critical for you to understand because at this stage, buying a new platform and trying to have that installed and some training delivered is extremely difficult in face of the travel restrictions in this outbreak. So it's important that you evaluate what you have available and what tests are compatible with the technologies you have at hand in your laboratories, and also with your staff has been trained on adequately so that you're not also trying to implement something brand new in the midst of the outbreak. Then we can move on to closed proprietary tests and platforms. These are more the cartridge-based system that I showed you in blue and white on the previous slide. And these are, again, our commercial companies that supply a test where everything is included in a single cartridge. Essentially, it's sample in and answer out. It's usually much quicker because there's liquid handling and microfluidics involved in the system. Turnaround time is around an hour, sometimes up to an hour and a half, but also they can be as quick as 5 to 15 minutes. It enables more automation, so you can actually usually get higher throughput or a really improved ease of use. So you can use this in a more decentralized testing strategy. However, you must have the install base available to you. So you must have the machines actually installed and available and trained personnel to be able to run them. Then you can quickly flip from testing your normal pathogens of interest over to coronavirus. And a good example of this is building off of testing facilities that have been in place for tuberculosis and HIV, as they use automated systems where manufacturers now have released assays and cartridges that are specific for coronavirus. However, I would caveat that to say that as an implementation of a health response program, you must also then balance out the needs to continue testing HIV and TB and ensure that you don't stop all of your other programming by taking over the use of the platforms. So if it requires procurement of new machinery and an install base or space and capacity, you'll have to take that into account in terms of your ability to scale and rapidly move forward through that, but then also the ability to actually get those equipments and supplies into your country if that's not already something that you have a supply chain and delivery mechanism for, as well as the installation support. So here's an example of some product overview. I would suggest that you visit our pipeline on our website, because we've got a much longer list. It's actually a little overwhelming to see the list of manufacturers that have come to the table with kitted and commercial solutions. You'll see for laboratory developed tests, there's quite a few labs that have developed those and are making them available through different websites, either the WHO website or the US FDA. There's a long series of manual molecular kits that are open. And then the closed and proprietary tests are somewhat more limited, but there is still a growing list of those that are available. And again, I highly urge you to look at these lists and be able to relate that back to the footprint and the technologies that you already have available in your space when choosing which test to implement. There's also some national regulatory authorities who have been approving different tests. The only thing I can say about these national regulatory authorities is that the level of data and performance that is needed for them to approve a test is highly variable and not necessarily exhaustive. And so I do urge you to understand, if you're accepting a national regulatory authority as an approved test, that you understand what was required to reach that authority and that approval, and make sure that there's sufficient data for you to feel confident in your decision for your health program. Decentralized widespread access to testing obviously is needed if we're going to scale and follow Dr. Tedros's advice to test, which is really the only way that we will get to understanding what is happening in our communities and how best to contain the spread. So point of care tests, which can be performed outside the laboratory, are critically needed at this time. A very good example of these are the rapid diagnostic tests, or the RDTs. They're usually based on viral antigen or antibody, as I just described, and they do enable widespread sample collection. You can either still transport to a central lab for confirmatory testing, or you may be able to set these up in mobile laboratories or mobile collection facilities to be able to do rapid tests. So when we're talking about rapid diagnostic tests, there's several unique features that are critical to remember for SARS coronavirus. This is a respiratory pathogen, so making leaps and linkages to other pathogens like HIV, dengue, Zika, or chikungunya are fine to make as long as you remember that this is a respiratory pathogen and so can behave quite differently than other viruses that we have more experience dealing with. The immune response appears to be slightly atypical. So most other viruses, IgM, becomes detectable in the blood after infection and then wanes, while IgG levels rise after the acute phase, so after the point where you're showing symptoms. In the coronavirus outbreak that we're seeing now, it seems that both IgM and IgG rise quickly after the first few days of infection and may remain high for weeks. However, we still do not know how long they remain high and whether or not this transfers lasting immunity. So you may have high levels of virus in the days before the onset of symptoms. This is something that I'm sure you've all been reading about, is the asymptomatic transmission of virus. So before you're starting to exhibit symptoms, there is evidence that you are shedding high levels of virus. So this would also be before your body has mounted an immune response. And so we would not be seeing detectable levels of IgM and IgG potentially. There is no specific treatments, and the goal at this point, of course, is to minimize the spread of infection. So when we're selecting tests, we need to focus on those that have the highest possible sensitivity, because our goal then is to make sure that we capture all active cases and that we don't miss anyone that may be in the early stages of infection. So as I described earlier, rapid diagnostic tests or immuno-based tests are able to detect antigen, which is the actual viral particle in your nasal secretions, or antibodies that your body has mounted in response to being infected, and we would detect those through blood, through a venous blood collection or a finger stick blood. There is discussions that potentially oral fluid could also be used for this. However, I would caution that this is still very early stage, and we do require additional testing to be able to confirm that those would be detectable with a high enough confidence. Antigen testing right now, as I mentioned, is indicative of active infection, while antibody-based testing can be used to detect active infection, or if it's in a persistent mode, would be detecting previous infection. So if we're to screen and triage patients who have active infection, an RDT antigen-based test could be extremely useful, as could an antibody test if it's present, if the test is positive in the presence of symptoms consistent with coronavirus. So the results interpretation of either test are critical to be able to understand what decisions to make and how to clinically care for the patients that are presenting. If we look at an antigen-based test, a positive result, if it was used as a screening test, means the person is likely infected. If you have a high confidence in this test that the positive predictive value is really confirming that you have active viral shedding, you do not need to necessarily confirm by PCR. However, if you're not confident in your predictive value, or the negative predictive value is not high enough either, you would then forward that sample on for confirmatory testing. At the same time, you would ask the patient to home isolate or be admitted into a healthcare facility if the symptoms were strong enough. So a negative result would mean that the person is likely not infected. And the question then is, how do you recommend that patient to go back into the community, not self-isolate potentially? So again, this comes back to the confidence in your negative result. If it's a low sensitivity test in the presence of symptoms, we would highly recommend that you do a confirmatory PCR test. If the patient is not exhibiting any symptoms, you should continue to monitor, potentially ask to self-isolate, and then do a confirmatory test later. So a false positive result, to remind you, is a person that is not infected, but will unnecessarily be placed into home isolation or be admitted to a healthcare facility to manage symptoms, but they are not infected. The risk of this is based on the performance of your test, but to the individual, this is a low risk. There's not too many detrimental side effects that can come from having a false positive. A false negative, on the other hand, is the high consequent result. Person is actually infected, but is missed and called negative. That person may not be able to receive the care that they need, and they may be released back into the community, not through self-isolation, and contribute to community transmission. If we look at an antibody-based test, so either IgM or IgG, or there's also tests that combine both of these together to increase the sensitivity, you would need to, the positive results, would indicate a current or past infection. You would still need to confirm whether or not the patient was actively infected. And that is either through a confirmatory PCR test or an antigen-based test. A negative result, on the other hand, would indicate that the person has not been exposed to the virus. However, and this is extremely important, it could be negative because they're in the early stages of an active infection. So in that window of time where you're actively shedding virus, but your body has not mounted a sufficient immune response so that we can detect it through antibody-based testing. You would still need to confirm that the patient is not actively infectious if they're exhibiting symptoms that are consistent with coronavirus. So what are some of the negative repercussions to the test's false positive or false negative results? So a false positive result, if used to screen for infection, the person would actually be uninfected, erroneously called positive, and will be asked to be placed into home isolation or potentially admitted to the hospital. Again, this is a low risk to the patient and is not the same to balance out a false negative. In a false negative situation, if it was used to screen for infection, the person is actually infective, likely within the window period, which is why you've been missed, which means that viral shedding may escalate over the coming days. The patient would not receive care if needed and would also be released back into the community to contribute to community transmission if not asked to isolate. If it was used to screen for immunity, the person is actually immune, but no action is taken, representing a missed opportunity to use that patient in an area of high risk, as opposed to the converse side of that for the false positive, where the person is actually not immune, you think they are, and you've put them back into the front line of working with high-risk patients, and they could potentially become infected and not know. So as we select for tests, it's important to select high sensitivity tests as they decrease the risk of false negatives, and high specificity tests that decrease the risk of false positives. However, there's always a trade-off between these two, especially in formats like rapid diagnostic tests or lateral flows. So just to give a very quick summary of uses, if we're looking to confirm active infection, molecular and open or closed systems are available, antigen RDT, rapid diagnostic tests are suitable, and an antibody test, depending on performance, can also be used. If you wanted to monitor disease progression, you could use molecular tests. Antigen RDT would be very much dependent on performance, as they may not be sensitive enough to actually track the course of infection. If you're looking to establish previous exposure and then make a decision about how to use healthcare professionals that are hopefully immune to the virus, you would want to rely on antibody-based testing. And if you were looking to implement population-based surveillance so that you could understand the levels of infection within your community, you would also rely on antibody-based testing, whether that be RDT, rapid diagnostic tests, or laboratory-based immunoassays such as ELISAs, which do tend to have much higher performance capacity. So once you've decided on your testing algorithm, it's important to select products and tests that fit within your algorithm, your setting of use, your training capacity, and your available equipment. Requirements for emergency use can vary substantially between countries, and it's usually less rigorous a bar to pass to be able to be listed. So it's important to understand those requirements and what data has been submitted. We do feel strongly that you should rely on selecting companies that meet international quality management systems, such as ISO 13485 or equivalent, as this will give you good confidence that the manufacturer of choice is going to be able to continue to provide access to the product and makes it at the highest standards. It is beneficial if you can prioritize tests that rely on an existing distributor or supply network within your system so that you're not trying to create a new avenue or route in for a test. However, I do think for coronavirus 19 outbreak, we're going to be seeing many more tests that you have never ordered before potentially becoming available and being of interest to your system. So it's incredibly important to understand how to get those tests in, what kind of regulatory and import permits are needed. Are those manufacturers able to export into your country, and how will you support them being used and if training is needed? It's critical that you ask any supplier for a copy of their instructions for use before implementing the test. It's extremely important that you understand what steps are needed to be able to collect a sample and use their test appropriately, as any deviation or changes from that could drastically impact the perceived performance of the test, and you must understand those changes before you implement them. And then we recommend that you consult independently generated performance data and not solely rely on the manufacturer's claim on performance. FIND is endeavoring to try to gather as much data as quickly as we can and make that publicly available. However, there are many other institutions that are doing scaled studies, some quite small and others larger, to be able to validate the use of products in their systems. And so we're also asking for anyone with available evaluation data to share that with us so we can aggregate it openly on our website so that countries and other institutions that don't have the capacity to do these evaluations themselves have access to that data and can use that in their information and in their decision making. I would like to stress as a laboratorian myself that biosafety is absolutely critical and cannot be ignored even in the face of an outbreak and even in the face of a ramping scaled response within your institution. The recommended biosafety level is BSL-2. You do need to do a risk assessment to understand the activities that you're taking in to place into your system, the level of training and personal protective equipment at hand, the ability to deliver on the testing and the results while keeping your staff and your healthcare workers safe. Disinfectants are straightforward enough. EPA-registered hospital disinfectants are effective against coronavirus, which is a big relief. Waste disposal can follow your standard procedures for other respiratory pathogens such as flu. And specimen handling, packaging, and transport should follow normal UN 3373 biological substances category B packaging and shipping. There's additional information for you on this at the WHO website that's listed on the right-hand side of the slide. So one of the things that has become critically important is trying to ensure that we understand how different laboratories are performing, to understand that they're actually executing on tests in a high enough quality manner that country health departments and ministries of health can rely on the data. So there are several different external quality assessment or EQA schemes that are becoming available. There's a couple here listed on this slide. This is not exhaustive, and we hear of many other groups starting to offer EQA schemes on a daily basis. We do suggest that if you want to participate in an EQA, that you choose a provider who's experienced delivering in your region. And we do have some additional work going on at FIND to try to support some providers to be able to make these rapidly available throughout Africa. And you can see some of them have a cost and others don't. However, the ones that don't have a fee associated are restricted to influenza reference laboratories. And so it will take a little bit of effort for you to find an EQA program, potentially that's ready to scale and ramp right now. However, as I mentioned, FIND is working to try to support the aggregation of additional data and also to support the ramping up of different EQA schemes within Africa over the next several months. You can also use quality assured materials for doing testing and evaluations of tests that you may want to bring in, and also as controls to understand that your staff are adequately trained and able to run the diagnostics, especially if these are new tests that you're implementing in your facility. There's different providers that provide standardized stocks or control material that are available for purchase. Again, the list on this slide is not exhaustive, and there is lots of other providers that are available to provide control material that are already provided inside some PCR kits, or that you can have yourself to be able to run alongside to verify how your tests are working. So some of the key considerations for diagnostic implementation within your system that we think you need to take into consideration focuses around country planning and policy. How will you actually deliver these tests? Where will you implement them, and how will they be used within the network of testing facilities across your region in your country? Your diagnostic network and other satellite sites that you'll be able to rely on, either if you do decentralized testing with referral back for confirmation, or if you rely on a centralized testing facility with a decentralized sample collection mode. The infrastructure that's available both from the biosafety component inside of things to your healthcare worker and staff, but then also to the instruments and platforms that are available to you now to be able to do SARS coronavirus 2 diagnostic testing. The training and level of experience of your personnel, the availability of the personal protective equipment to keep them safe while they're doing this work, The strength of your lab clinical interface must be taken into account so that you can rapidly share results back, especially if decentralized sample collection with a centralized testing modality is chosen. Your biosafety and quality assurance, this was just discussed. And then, as mentioned earlier on in the presentation, the supply chain requirements. So FIND is going to be very soon opening up an online technical assistance and laboratory training course for SARS coronavirus. We're partnering with ASLM and the London School of Hygiene and Tropical Medicine to be able to develop an online learning platform. It will have learn at your own pace training modules, and we'll be able to rapidly provide training and guidance on various diagnostic platforms. So you have one central site that you can gather information to be able to leverage rapid training of your staff in your institutions. We hope to have this ready for launch by mid-April. So just to point out some outstanding questions around SARS coronavirus and the outbreak, the overall kinetics of expression of the RNA and the viral antigens, as well as the specific antibodies, are still not clearly understood. There's additional work that needs to go into this so that we can understand how each of these biomarkers can be used and with what confidence, depending on your question that you're posing, which should center around either, is a patient actively infected, or have they been previously exposed and could they potentially be immune? Despite the tremendous speed and the sheer number of tests that have been developed for COVID-19, there's minimal independent data verifying the accuracy of these tests. You may have heard in the news several countries that were placing very large orders for rapid diagnostic tests that have since had to be paused or canceled due to low performance data that has just recently become available. It's incredibly important that you evaluate the tests or you rely on an external party that has evaluated these tests to understand how to properly implement them within your facility. I will only touch very quickly on this so that I can give Rosanna Peeling an opportunity to speak, but there are additional research work going on to the implementation of next generation sequencing. And so if this is something that your institution is capable of supporting from a resource and infrastructure and capacity situation, then this is another option for being able to do surveillance. However, I do caution that there is complex bioinformatics that requires training and capacity building and data sovereignty issues that need to be addressed at your country level so that you understand where your data is being shared and stored. Additional resources that are going to be made available in the slide deck are here, and we hope that you're able to access them and be able to get more information to help you make decisions for the implementation of diagnostics in your laboratories. Thank you.
Thank you very much, Cassandra, for the wonderful presentation. Quite a lot of important information indeed. Would like to move on and get to the next presenter before we take questions. Our next presenter needs no introduction. That's Professor Rosanna Peeling from the London School of Hygiene and Tropical Medicine. She's going to talk to us about rapid test kits and Africa CDC strategy. Over to you, Prof.
Thank you very much. Can you see my screen?
Not yet.
Okay.
Not yet.
Yes.
Yes.
Can you see it now?
Yes, we can see it
Okay,
now.
great.
So you can.
Okay,
Wonderful.
thank you. Thank you, Navi. So thank you, Cassandra, for a really comprehensive review of testing. And I think that what we really like to do here is just to capture some of the main use case scenarios for testing in any outbreak response. So in particular, I just like to emphasize that because of the dynamics of the infection, where there are after date of onset, there are only several days that you could really ideally use a molecular test, because that's a period when the patient sheds virus. And then after that, when antibody levels come in, then you could no longer detect virus, and antibody tests are, what you could use to try and retrospectively say whether a patient had an acute infection. So the emphasis is on the right test for the right patient in the right place at the right time. And so, although there are many use cases for diagnostics for COVID, I just like to very quickly go over 4 main use cases to confirm infection in patients that fulfill the COVID clinical case definition, which Cassandra has talked about. The rapid triage of suspect cases, especially in community settings, in a clinic, within the community, or in a district hospital, to screen for infection in asymptomatic contacts of confirmed cases. And then finally, to determine exposure, either current or past, to the virus, so that we understand the true extent of an outbreak, may be able to map the epidemic across the country, monitor trends in number of people who are exposed or infected, and then for contact tracing. Now, the first use case to confirm infection in patients fulfilling the COVID case definition, typically we need a test with the highest sensitivity and specificity to detect viral RNA. And optimally, this needs to be used within 5 to 7 days post-onset of fever for it to be effective. And Cassandra has gone over where it could be done. Usually it's in a lab setting, requires specialized equipment and trained laboratory staff. And typically it takes 1 or 2 hours before the results are available. For use case 2, the rapid triage of suspect cases, what type of test is needed? Usually, we hope that you have the ability to access rapid tests, either the point of care molecular tests that Cassandra talked about, that are sample in, answer out, for you to be able to detect viral RNA. And I show here some examples of these point of care machines. We just had news yesterday that the FDA had approved a rapid viral point of care test that could give an answer in 5 minutes, which is very good in terms of a quick triage. You could also have a rapid test that could detect viral protein. It could be in the form of a lateral flow test. I'd just like to go back to the use of the point of care molecular test. A lot of these small machines that are point of care machines, they do have data connectivity. So you can imagine in a country, if you know the locations of these machines, you could actually quickly have a real-time data visualization of the number of cases per location across the country. And that's something that is really useful in trying to track an outbreak. And so these tests could usually be done by anyone who could follow simple instructions, because as I mentioned, it's sample and answer out. So the hands-on time is very small, and in a matter of minutes, you just have to be able to take an adequate sample and put it into the cartridge and insert the cartridge into the machine. And there are quite a range of them. They range between, the molecular tests range between 5 to 45 minutes before you could get a result. And of course, the lateral flow type of point of care antigen detection tests typically take 15 to 20 minutes. In use case 3, if you need to screen asymptomatic individuals who are contacts of a COVID case, then it's a little bit more tricky to try and figure out what type of test to do, because it really depends on the timing of the exposure. So for example, if you're doing an investigation of a cluster of people who had been at a social event, and eventually one of the people from this event got severe disease and present to hospital and got confirmed as a case, and then you try to trace back to all the individuals who were at that gathering, but 20 days may have gone by before this happened. So then, depending on the time of exposure, if it's within 7 to 14 days of the event, you could use a lab test to detect viral RNA or antigen, or a point of care test. But if it's more than that, then you have a better chance of getting good results using a serology test. And Cassandra already mentioned IgM and IgG tests. They almost, in this case, rise together rather than first IgM and then later on IgG. Now, because this is also it's a respiratory infection, and the site of infection is the of entry is the mucosal layer. So we do have some anecdotal reports of IgA tests being useful as a marker of exposure as well. So that remains to be seen. We don't know very much about the performance of these serology tests at the moment to know which test to recommend. Now, learning from the experience of dengue tests, we know that perhaps a combination of molecular tests and serology tests, or a combination of antigen and serology tests, may give us a wider window with which to detect infection, especially in symptomatic cases who have been contacts of confirmed cases. So use case 4, to determine current and past exposure. Cassandra went through that in quite some detail, so I won't take a lot of time to do that, other than to say that there are geo tests where you could detect IgM and IgG in one combination of cassettes or in a single test. There are also some oral tests that you could use at home. We don't really know how good they are, as we know that because Cassandra explained, this is not a blood-borne infection, so typically antibodies are not as high. And so the amount of IgM or IgG or IgA antibodies that may have gone into the oral fluids, the transudation may not have been that good. And so there may be just very low levels of antibodies in saliva or oral fluids. So be very careful if you're thinking about recommending home-based or self-tests. And so, and these tests normally can use finger prick, whole blood, plasma, or serum. And so when a lot of countries are slowly running out of supplies, either for PCR or for swabs to take samples for PCR, it may be useful to think about how we could use these antibody detection tests. So let's think about the testing strategy. WHO has defined the 4 C's as no cases, sporadic cases, clusters, and community transmission. And Cassandra has already gone through that. But on the whole, a testing strategy really depends on the stage of the epidemic you're at and the laboratory or diagnostic capacity within the country and what you could access in terms of supplies. Now, Africa CDC has some time ago disseminated this testing strategy in two parts. One is, if your country is in an early outbreak situation, test anyone with fever and acute respiratory symptoms who had been in a place in the last 14 days where COVID is circulating. And that person may not be in that place now, but if there's a history, then you should certainly test them. You should certainly test all symptomatic contacts of a confirmed or probable case. And that is usually using a PCR or molecular test, as well as for those who are suspect cases. And then you should also test all cases of severe respiratory infection, acute respiratory infection surveillance systems, and also select samples from your influenza-like illness surveillance systems, because these may be an indication of whether you have COVID in your country, or how many of the people with these with these syndromes actually are infected with COVID. And then lastly, test healthcare workers with symptoms that are consistent with COVID-19 disease, regardless of exposure. And that's very important for you to, one, if they're infected, take them out of circulation so that they don't infect any patients that come into a hospital setting or a clinic setting. And also to then quickly be able to figure out how you can maintain a strong workforce for the epidemic. Now, in the case where community transmission is established, then you should prioritize all cases of your surveillance systems, either through the severe acute respiratory infection surveillance system or the influenza-like illness surveillance system, because then there may be a higher proportion of those who would be your COVID cases. And certainly, again, to confirm all the respiratory infections presenting to the hospital that are consistent with the case definition for COVID. And then healthcare workers with symptoms consistent with COVID-19, regardless of exposure. So those are the two testing strategies for countries that are earlier in the outbreak, and that's corresponding to WHO's definition of no cases, sporadic cases, or clusters of cases. And then this particular strategy for when you already have a slow infiltration of cases and that there's community-based transmission already established endemically. Now, so I'd like to use this opportunity to have a discussion with all of you about the role of antibody tests. And so you could imagine that in a place where you've completely run out of possibility to do PCR tests, is that a place that you could use these serology tests? So I think that in terms of knowing how much of the acute respiratory infections or influenza-like illness infections are due to COVID, perhaps you could use an antibody test as just as a total indication of exposure of your population to the virus, and that would give you some idea of how serious the higher the proportion of these that are confirmed to be COVID or had antibodies to COVID, then it means that you are in a more serious situation with regard to the outbreak. The other use would be to use antibody tests to map the extent of the epidemic in order to inform public health measures. Now, people have asked about using these antibody tests as a means to measure herd immunity in order to know whether to stop very restrictive measures that have been imposed. Now, measurement of herd immunity in the strictest sense should be measurement of protective antibodies or neutralizing antibodies. And right now we don't have any test that's specifically for that. Now, if you use the rapid tests that are currently available, they measure exposure. If it's very specific, they measure exposure to this particular coronavirus associated with the outbreak. But what we don't know is that if you use these, do you know the general background of antibody levels to coronavirus in general? Because this is the winter season, and normally we do have a lot of coronaviruses that cause cold symptoms. And so we don't really have good studies to let us know if any of these current RDTs in fact pick up the normal level of coronaviruses and not just COVID. And so that's something to consider. And also, as Cassandra said, you wouldn't be picking up people who are acutely sick, who are still in the window period. Now, also antibodies tests can also be used to determine at-risk populations to know which age group, for example, we know from antibody tests as well as molecular tests that the elderly with comorbid conditions are the most at risk, but maybe we could use antibody tests to map different at-risk populations. And if we have a good comprehensive sort of data set with a good denominator, we can even calculate the attack rate. And in some countries, antibody tests, because PCR is not always available in some hospitals, or that there's such a queue to use PCR to confirm cases that are coming in, the discharge of confirmed cases from hospital may become an issue. And so some countries are using serology tests to try to confirm that people can go home, assuming that once you have antibody levels, then you are no longer shedding virus and you've recovered. But that remains to be confirmed how good that is. And then, of course, as Cassandra mentioned, you could also, if people are antibody positive, especially healthcare workers, they could return to work if they have been in self-isolation, or they could be placed to work with patients who are more severely sick. So I'll stop there, and maybe we could have some questions from the audience to see what we could do in terms of the use of serology tests. Thank you.
Thank you, Prof. Quite interesting insights indeed. So now it's time for questions. We know we've gone beyond the hour, but we are happy to extend it with 30 minutes to at least take some of your questions. We acknowledge that there are a lot of questions that are in the chat box. So for those that we may not be able to answer, we will collect these, share with the presenters, and be able to share with you their responses as well. Let me take the first few questions that we received from the audience. The first one being from so many indeed. Many of them were really talking about whether we will share the presentation. So this is going to be shared. The first question that I'm taking here is from Wilbur Sabiti. And he says antibody tests are widely expected to help review whether a population has generally achieved a level of herd immunity to SARS-CoV-2. Do you think these tests will achieve this goal given the shortfalls you have highlighted? I think this was directed to Cassandra.
Hi, thanks for the question. So I think that the test definitely will be able to contribute to that. The question is what format of the test. So are these going to be in the more sensitive and specific versions that require laboratory infrastructure, so the ELISA-based or the automated systems, versus the RDTs or the rapid diagnostic test, the lateral flow test strips, whether or not they're going to achieve the performance that we need to be able to do population-based immunity screening. We hope that they will get there. At this point, there's some claims by manufacturers that we should be able to get close. And so hopefully in the next couple of weeks, we'll be able to confirm that.
Thank you, Cassandra. And Prof, I think this is also similar to what you were discussing. Any reactions?
Yes, I think that, like Cassandra says, it's really important if you do think about using this for herd immunity. It's only a surrogate marker because I don't think any of those tests would be an indication of whether people have protective antibodies, and that's what you're counting on. But in general, if you have 60 to 70% of the population antibody positive in general, then hopefully a large number of those may have protective antibodies, and therefore you've achieve a level of herd immunity. I think the idea of herd immunity is that when you have so many people who have exposure to the virus, and the number of susceptible people are then few and far in between, so that the transmission cannot take place as readily. Because your susceptibles may be physically far away, as well as you wouldn't have in a group a lot of susceptible people to be for the infection to be transmitted. Over.
Thank you, Prof. I'll take the next question. I think I'll take this by themes. One of the number of questions that were being asked was around validation. Caridia, I had inquired, can you explain what validation or that find is doing? This also goes together with the same from RDE, we had said RDT, both on antigen and antibody, have been mentioned on both presentations. But do we have performance evaluation data for this? Over to you both.
I can touch base quickly on the evaluations that FIND is undertaking. So we've prioritized 17 different manual molecular kits to be evaluated, and we expect to have that data available in the next week or two. And then additionally, on top of that, we're also looking at the evaluation of the automated systems. Those will come in a couple later weeks, as we need to ensure that the labs that are doing the testing have the platforms installed and ready to go. And then from the rapid diagnostic tests, we're prioritizing 4 antigen-based rapid diagnostic tests for evaluations that should start by Wednesday of this week. And then we'll be prioritizing and finalizing the list for the antibody-based RDTs by tomorrow or Wednesday at the latest. And we hope to start those studies next week. We expect that the RDT studies and the evaluations will take a week or two to complete, as we're expecting to enroll between 1,000 and 2,000 patients per test that we evaluate to ensure that we have good positive predictive and negative predictive values that come out of those studies. Just a very quick note on the types of studies we're performing. We're doing a verification of the claimed sensitivity of the test. So what the manufacturers are claiming, we're hoping to double check that and ensure that they haven't overstated their claims. And then we're going to be testing each of the assays using patient samples that have been collected and tested with a gold standard test. So these would be either remnant samples for molecular tests or prospective collections for molecular, and definitely prospective collections for any of the RDTs.
And I do know that some governments have been evaluating these RDTs, but the data are not available publicly. But I wish they could share them with WHO so that nobody needs to reinvent the wheel. I do know that the UK government, Brazil, the Anvisa, the regulatory agency, has also approved some kits, and so if those are publicly available, I'll be sure to share them through this platform. Over.
Thank you, Prof. And indeed, once Prof shares, we'll distribute, I think, widely. Along the same lines, a question on using the antibody testing. Is there a way of distinguishing between the antibodies from SARS-CoV-2 from those that are produced from other coronaviruses? This is from Augustine Onyegala.
Yeah, I don't think enough studies have been done to know the extent of cross reactions. I think that with regard to antibody tests, it very much depends on the diagnostic target that the test developer picks. Most of the diagnostic targets are using the spike protein, and there are a number of conserved epitopes for different types of coronavirus have the same type of epitope. So if they happen to take that as a diagnostic target, we'll see many cross reactions. But hopefully many of the companies are able to pick a diagnostic target on the spike protein that's unique to this particular virus. Then we will have a much more specific test. So a lot of it depends on the choice of targets. Yeah.
Thank you again, Prof. There were quite a number of questions with regards to the Cepheid GeneXpert test. So I'll pick one of them from Brian Keenan, and she says, question on SARS-CoV-2, is a biosafety cabinet necessary for the sample manipulation prior to running the test? As we are thinking about decentralization of COVID-2 molecular testing, the availability of biosafety cabinets could become a barrier. So this was one of the questions around the expert. And thanks to Cepheid colleagues who have answered some of the questions in the chat.
Nafi, okay, so I think in starting to process a sample, we usually recommend that you at least use a biosafety cabinet level 2 to do the initial sample processing. But once you add the first reagent into the sample, you've already inactivated it. And so the sample is then safe to be used anywhere, and so that you don't need to put the machine into the safety cabinet.
Thank you, Prof. Indeed. Moving on, I think randomly also picking the next one, I think on a different subject, issues of supply chain. I think Kelly touched on these and are really important indeed. And Tanzile says, how do we envisage supply chain for laboratory products being affected during this period? And what measures should be taken to minimize its impact? Maybe in a summary, Kelly.
Absolutely. It's a great question. And I think one that all labs are struggling with right now is how to keep up with the demands for all the reagents while they're in global demand, which is unprecedented. We've never seen every single country demanding the exact same test kits, swabs, and medical supplies. So there's a couple of different endeavors that are going on right now. WHO has a donation program where manufacturers can donate products, and then those are going to be distributed. They're also working on an allocation prioritization project to understand how WHO and other government officials are going to ensure that countries are equally given access to reagents. And so I do think that this is a critical question, one that requires a very strong voice from leaders like ASLM and ACDC, Africa Centers for Disease Control, to ensure that we have equitable access to the tests and reagents that are needed. It's something that FIND we're also trying to be very strongly advocating for, to make sure that we don't just see manufacturing and supply going into the countries where the manufacturing sites are located. So I can't give you a perfect answer, but I can say it is on everybody's concern list right now. It's being discussed heavily, and that I think we have to all continue to advocate. And one mechanism for that is to ensure that you have good visibility into the numbers of tests that you think your centers and your governments then therefore will need, and how to roll those numbers up so that you have a clear ability to advocate for the supply and demand that you foresee in your countries and in your sites.
Yes, I would totally support that point, because it really helps the companies to know in terms of production numbers if there are good demand forecasts from different countries or from Africa CDC. It would really help, and that's the question I often get from companies. You know, how many should they try to produce? And whether they could ramp up production quickly, or whether they should, just go on as usual. So those are really, really important questions for every country to consider in terms of having a demand forecast to be done accurately.
Thank you very much. I would also like to take this opportunity to also get some perspectives from some of our colleagues from the donor community, as well as implementing partners. I don't know if Yenu is online.
I don't think Yenu is online, Anafi.
Okay, all right. Any folks from PEPFAR CDC? I saw George earlier on.
I think George and Clement.
Okay, there's May speaking. All right. Maybe whilst they are preparing, let me just get one more additional question along the same line on supply chain. An interesting question that came through around, do we have the costs for these RDTs and the affordability in terms of market, given the situation we are in right now?
Cassandra, do you know?
It says, can FIND help ensure affordable prices and market control? I think that's how the question came through.
Yeah, it's a great question. So we're working with different providers to understand what their pricing is. I have to say some of the prices that we're hearing are not what I would call affordable, globally anyhow. And so we're already raising that point with several of the manufacturers, CEOs, and heads of their manufacturing facilities. The other ones that we're evaluating right now, I have to say that we're first focused on getting the evaluation data available to countries so that we can make better decisions about which tests are going to be widely applicable and widely needed. And then I think, based also on the volume discussion that we just had around how much stock and supply our country is going to need, we can actually leverage them to ensure that we have aggregated volumes that could bring down pricing potentially. This is something that we actively do at FIND, and I know WHO is also working on this through their supply chain efforts. But at the moment, I can't tell you what all of the final pricing are going to be. We've only heard for one or two.
Thanks, Cassandra. Indeed, this is an evolving situation, and hopefully we will learn as we move on. Aileen also has an interesting question. Aileen, are you there? Around manufacturers and kits.
Yes, I am. First, I want to thank the presenters and ASLM for an excellent session. Very, very informative. Thank you so much. My question is, do we have any data on diagnostic manufacturers in the Africa region?
Elio, do you want to take that?
I can try to address it. So, so far of the manufacturers that have applied for the FIND evaluations, there have been no manufacturers from Africa continent. We do know that there are several different initiatives to try to have some manufacturing capacity in sites that would come online to be able to manufacture some tests within Africa. However, I don't believe that those are going to be up and running in the short term. I think they will take several months to a year to become operational. So I think it will be a gap that won't be addressed at the beginning right now. Hopefully we have some better options for tests that come out of Africa to serve Africa in the next couple of months though. Rosanna, I don't know if you want to.
Yes, I think there are a couple that are in Africa, South Africa, Senegal, but they're still gearing up. So they won't be in a position to manufacture right now or in the next few months. So.
Thank you. Indeed, time is not on our side. So I'm going to take about 2 questions before we wrap up. Randomly picking. Hello? So randomly picking one here is on, I think some of these are comments. Someone says, instead of buying more platforms, the easiest and more cost-effective approach is to increase lab shifts. This is particularly advantageous for high throughput platforms as they will run the bulk of SARS-CoV tests too, and ensuring that volumes of HIV viral load and other molecular assays are run. I think it goes hand in hand with a few that we're talking about. Let's not forget about the other testing. Any comments on that?
This is Cassandra. I so strongly agree that we can't forget about the other programs that everybody's been working so diligently over the decades for. And also these are the patients that could potentially have the most serious side effects from infection with coronavirus. So it's incredibly important to keep up those testing programs. But I have to say I do worry as the manufacturers switch their manufacturing lines to try to meet the demand for the coronavirus assays. How will we ensure stability of the supply chain for the TB and HIV tests is a question that I think still remains to be answered, and that several organizations are posing right now and trying to get a sense for how we're going to be able to balance all of this globally.
Thank you. Prof, any comments?
No, thank you.
All right. The last question I'll pick from the list, and we promise that we are going to collect all these questions and so many important questions that have been asked. I saw also great answers coming through, people talking about how they are hitting the virus as well in order to inactivate it. So I'll pick something around specimen quality. I think this was from Bobby and Japheth. And they're saying any insights into the impact of specimen quality into quality assurance of results. Some materials are coming up showing bronchoalveolar lavage samples having better chance of detection than pharyngeal swabs or nasal swabs. Over to you.
Yes, yeah, I think the indication from the data from China showed us very early on in the epidemic that the specimens from the lower respiratory tract, such as sputum or bronchial lavage, are much more likely to be positive than throat swabs or nasopharyngeal swabs, which come from the upper respiratory tract. And that's because the site of infection, the receptor for the virus, is actually deep in the lungs. And so, so if you could get a lower respiratory tract sample, of course, then you will have a higher viral load and be able to more likely have a positive result. but then there are biosafety issues with the collection of these lower respiratory tract samples. So unless a person is hospitalized and have severe disease, usually those are not collected. The most important thing would be to be able to at least collect a nasopharyngeal swab or a throat swab or nasal swab.
Thank you very much, Prof. In closing up, let me give 30 seconds to Cassandra for closing remarks.
Oh, thank you everyone for your very insightful questions and very engaging dialogue on the chat system. It's amazing to see how active everybody is. I just wanted to also say that all of the data that we're gathering from our evaluations will be made available on our website. As soon as we've got it, it will be up for public use. We're also listing, besides the pipeline, we're also listing our criteria that we're using to prioritize different tests and which tests will be prioritized for evaluation. So that's also openly available for you in case that helps with any of your institution or country level decision making. We're also going to post some additional information on the types of diagnostics, specifically around the RDTs, so the antibody and antigen-based diagnostics, so that can help inform your testing guidelines and triage decision making. And I just wanted to say thank you very much again to ASLM for hosting the webinar and for giving me the opportunity to present. Thank you.
Thank you. Prof, 30 seconds.
Yes, thank you very much for the opportunity to present. And I really like to be able to elicit from different people who are participating what they're in their country. Are there different uses of antibody-based tests? And if there are, could you let us know how well it worked or not, etc. And because this is something that we need to really think about as we anticipate the outbreak will evolve in Africa. We need to be fully prepared to make use of every type of diagnostic available for outbreak response. And the more experience we have with different countries and the way that they've managed to use antibody tests would be extremely welcome. Thank you to ASLM and Africa CDC for this session. Thank you.
Thank you, Prof. And mine is left for me to thank all of you for coming here to share your knowledge. We appreciate all the expertise that you are sharing within the platform. Just to announce that we are going to be communicating soon regarding the upcoming sessions as we try to fight this war against COVID. And this is Anafi closing. Bye-bye.
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 Bye.
Bye-bye.
Bye, Samiti. William.
Bye-bye.
Goodbye.
Bye-bye.
Thank you.
Bye. Thanks very much. Bye-bye.
Bye.
Thanks very much.
Bye.